Today we're fortunate to hear from our Dr. Mannish Balwani on acute porphyrias. Dr. Balwani received her medical degree from the University of Bombay, followed by a master's in genetics at the University of Pittsburgh. She completed her internal medicine training, followed by a fellowship in medical and clinical biochemical genetics. Dr. Balwani currently serves as the director of the Lysosomal Disease Program and the Porphyria Center here at Mount Sinai. She's an investigator in the NIH-supported Rare Diseases Clinical Research Network's Porphyrias Consortium and serves as the principal investigator on several natural history as well as interventional clinical trials. Please join me in welcoming Dr. Balwani.
Thank you for the introduction, Rachel, and thanks for inviting me to speak to your group today. So I'm happy to represent the clinical arm of the Department of Genetics and Genomic Sciences and share with you what we do in the rare disease world. A clinical focus of mine for the past many years has been the Porphyrias, and in fact we have a Porphyrias Consortium here, a Porphyria Center here for the past 10 years. And I'm going to share our experience today about the acute Porphyrias, talk to you about the diagnosis, management, and beyond. So I know many of you are thinking, this is a rare disorder, I'm never going to see a case. But I hope to show you that these disorders are not quite as rare as you think. And in fact, these patients may be hiding among patients you see in the ER, on the medical floors, and even in your offices. So here are my disclosures. So I've divided this talk into a brief discussion of the overview and pathophysiology. I'll keep the talk of biochemical pathways to a minimum this morning. I'll talk to you about the prevalence of this disorder and then focus the majority of the time talking about the clinical presentation, diagnosis, and management. And then I'll end by talking about some of the newer therapies under clinical development, which is the beyond in the title. So the porphyrias are inherited disorders of the heme metabolic pathway. These are classified into erythropoietic or hepatic, depending on the primary site of the defect. The acute porphyrias are defects in hepatic heme metabolism. There are 3 autosomal dominant forms and a rare autosomal recessive form, which is too rare for this discussion. Each of these 3 autosomal dominant acute porphyrias results from a partial deficiency in one of the enzymes of the heme biosynthetic pathway. So these patients have about 50% normal enzyme activity, which is usually enough for normal heme homeostasis. And they need the presence of other precipitating or triggering factors to present with symptoms, and I'll discuss that later on. So here's the schematic of the heme biosynthetic pathway. The final product of this pathway is heme, and the intracellular free heme pool in the liver provides negative feedback inhibition to ALAS1, which is the first and rate-limiting enzyme in this pathway. This enzyme is the key factor regulating this pathway. Each of these enzymes represented in red, deficiency of any of these enzymes corresponds to one of the acute porphyrias. All of these present in a clinically similar manner, and I'm going to use acute intermittent porphyria, which is the most common of these, as my example today. It's a deficiency of the enzyme hydroxymethylbilane synthase, or HMBS. So under circumstances where there's a partial enzyme deficiency here and this pathway is overactive by precipitating or triggering factors, there is a block here, and there's an accumulation of ALA and PBG, and I'll discuss that more clearly later on. So here's what we know about the pathophysiology of this disorder. The heme pool provides heme-mediated feedback repression to ALAS1, but when the intracellular free heme pool is depleted or there's upregulation of ALAS1, the negative feedback inhibition to this enzyme is dysregulated, and there's an upregulation of this enzyme and this pathway is overactive. There's increased production of ALA and PBG, and under this circumstance, this 50% enzyme activity is no longer sufficient for normal heme homeostasis. There is a block in the pathway and an increased accumulation of ALA and PBG. Now, ALA and PBG are called porphyrin precursors. These products are extremely neurotoxic to the body, particularly ALA, and these are responsible for the multisystemic manifestations in acute porphyrias. So while we knew about the pathophysiology of this disorder from the historical literature and clinical observations, there was actually very little evidence supporting this. And some of the real evidence about the pathophysiology came from studies of liver transplant in Europe and the US. And this patient I'm talking about today was the first US liver transplant for acute intermittent porphyria. This patient was transplanted at Mount Sinai a few years ago. And this was a patient who was 36 years old at the time of transplant, but she was struggling with acute attacks for over 11 years, since her mid-20s. And she'd really exhausted all medical management. She was on treatment, she was not responding. And in fact, her pain was so severe, she was hospitalized for almost 13 months prior to transplant. This patient was referred to us for further management, and thanks to some great lobbying by my colleague, Dr. Larry Liu, we were successful in getting her a liver, and we learned some very valuable lessons from this liver. So we saw that urine ALA and PBG in this patient normalized within 24 hours post-transplant. We had some time to plan for this liver transplant. We were able to collect samples pre and post-transplant. And you can see that post-transplant, there's a rapid reduction in urine ALA and PBG. And even more importantly, this patient did not have any attacks in the years following transplant. So the story of liver transplant confirms that the hepatic defect is responsible for acute porphyrias, and liver transplant is actually curative for acute porphyrias. And I want to give a shout out to one of our former medical genetics fellows, internal medicine medical genetics fellows who collected the data on this patient. She was in the OR overnight collecting samples hourly. So this really contributed to this work. Even more important, we learned some other lessons from the liver. We learned that hepatic ALS1 mRNA is significantly increased in the liver of patients with acute porphyria as compared to controls. And this information becomes very relevant later on because this suggests that ALAS1 could be a potential therapeutic target in this disorder. So what about the prevalence? We've heard from the literature it's extremely rare. The only time people hear about this disorder are on medical mystery shows like House and others. But there are studies done in Europe and the US which give us a good idea about the prevalence of this disorder. So one of the first studies came from a French group where they looked at the presence of HMPS mutations in blood donors in France. And they found that the presence of mutations were about 1 in 1,700 in these patients. So that's not quite very rare. More recently, there were studies done at our group at Sinai where we looked at HMPS variants from exome databases. And we went through the additional step of expressing these HMPS variants. And we found that the total pathogenic variant frequency in the HMPS gene is about 1 in 1,800, which is quite similar to the French study. But if you look at the number of diagnosed cases, this number is strikingly different. It's about 6 per million, which is very different from the number I presented earlier. So where are these cases? One of the possible explanations is that this disorder has extremely low penetrance. And in fact, about 90% of patients who carry an HMPS mutation will not have clinical symptoms or biochemical evidence of the disease. They will be completely latent. And the other possible explanation is misdiagnosis. These patients present with common symptoms, as I'll show you, and it's easy to miss the diagnosis. So before I move on to the clinical presentation, I wanted to show you the age at clinical presentation. This is data from the longitudinal study of the Porphyrias Consortium. It's 208 patients with the acute porphyrias, and this graph shows the age of onset of symptoms. You can see that a vast majority of cases present in the 2nd to 4th decade of life. Moving on to the clinical presentation, I thought I would use a case was actually seen at the medical floors at Mount Sinai. This is a 30-year-old male who presented with acute onset abdominal pain, nausea, vomiting, and elevated blood pressure. He went to his local emergency room where they did a CT scan and diagnosed him with a presumed colitis. And he was given a course of Levaquin and Flagyl, given pain medications, and then discharged. But his pain did not improve, and he returned to the emergency room the next day. And because his pain was so disproportionate and they had no idea what to do with him, he was transferred over to Mount Sinai for further management. So at Mount Sinai, this patient had another CT scan and then had an exploratory lab with an appendectomy because there was a thought that he had some adhesions related to a prior hernia surgery. And post-surgery, he had some partial relief of symptoms. They sent him home with some pain medications. But this patient returned a few days later with continued symptoms. His abdominal pain was unremitting. And at that time, he had a further workup, including an endoscopy and colonoscopy. But at the time of the first admission, he was seen by a physician who considered acute porphyrias in his differential diagnosis. I went back to his medical records to see who ordered the test. It was one of the surgical residents. And they ordered the correct test for this, but unfortunately, the results were not back. But during the second admission, this patient was seen by Ron Parman in gastroenterology, who some of you may know. And Ron Parman picked up that abnormal test and he followed up on the diagnosis. He had some help from Robert Clafter in hematology, and they repeated the confirmatory test. And in fact, this patient did have an acute porphyria. And this patient was referred to us for management. And the history we got from this patient was that he started on an Atkins diet just about a week prior to the onset of symptoms. So the Atkins diet, for those of you who don't know, is a low-carb diet, which was very popular a few years ago, and this patient had started it as part of a New Year resolution. So this patient presented with the classic symptoms of an acute porphyria. What was unusual in this case was the time to diagnosis. He was very fortunate that he had physicians who considered this in their differential diagnosis, and his diagnosis was made in 2 weeks. Most of our patients are not quite as lucky. They go for many years without a diagnosis. And this case was such a great diagnosis, it was featured in the Well blog of the New York Times a few years ago. So I presented this case with classic symptoms, but if you look at data from larger natural history studies, you can see that some of the most common symptoms in these patients are abdominal pain, nausea, weakness, and constipation, certainly common symptoms seen on your floors in clinic. I want to say a little bit about the neuropathy in acute porphyrias. I mentioned that ALA is extremely neurotoxic, and I've told you about the effects on the autonomic nervous system. But these patients also have a very severe peripheral neuropathy. They develop an acute axonal motor neuropathy, which can be progressive and in fact can progress to respiratory paralysis. They also get very extreme pain in their extremities. They have involvement of the sensory nerves. And they get central nervous system involvement. They can get anxiety, they can have hallucinations and symptoms of psychosis. They can be very agitated. And of course, about 10 to 20% of these patients will present with seizures. So just a little more about the abdominal pain in this disorder. It's one of the most common symptoms you probably see in your practice, but this abdominal pain is a bit different. The pain in these patients is not localized. It's actually diffuse pain. And pain, in addition to abdominal pain, these patients also have pain in their chest, back, extremities. And these patients have an absence of peritoneal signs. So this flow chart just illustrates what I told you. If a patient is febrile, it's unlikely to be an acute porphyria. If the pain is short-term, it's less than 24 hours, it's unlikely to be an acute porphyria. If there's localized pain or rebound tenderness, acute porphyrias is likely to be your diagnosis. Now, I mentioned these precipitating and triggering factors in these patients. These patients are susceptible to the effects of these factors because of their partial enzyme deficiency. And the most common precipitating factors in these patients are drugs. Some of the more common drugs are hormonal contraception. We often see women who have started hormonal contraception starting with their first attack. The other common drugs are sulfonamides, hydantoins such as phenytoin, barbiturates, but any drug which can induce the hepatic cytochrome P450 system can actually precipitate an acute attack. Women are most susceptible to acute attacks during the luteal phase of the menstrual cycle and during pregnancy and the postpartum period. Infection, stress, surgery, fasting are all precipitating factors in these patients. In fact, there have been several reports of acute porphyria attacks precipitated post-surgery, particularly after bariatric surgery. So here are some of the other clues to the diagnosis of acute porphyrias. These patients present with dark or reddish colored urine, and in fact this photograph I have here is a picture which we were given by one of our patients. And you can see that the urine is this dark, almost wine colored urine. So if you see a patient who has this dark or reddish urine, about 70% or so of patients will have dark urine during the acute attacks. This should give you a clue to the diagnosis. One of the common findings you see on routine labs in these patients is hyponatremia. They have inappropriate ADH secretion and renal and GI losses which can contribute to the hyponatremia. And in fact, the hyponatremia can be quite severe. We've seen patients with sodium levels below 115, and they can become medical emergencies, and some of this may precipitate seizures in these patients. But if you see a young patient with new onset hypertension, that could give you a clue to the diagnosis. These patients also have profound muscle weakness, a young person with very severe muscle weakness. Women are more likely to have attacks than men due to hormonal factors, and these patients typically present in the 2nd to 4th decade of life. And if you have a history of ingestion of certain drugs or infections or stress or dieting or fasting, this could certainly give you a clue to the diagnosis of this disorder. So I wanted to say something about PRES because this has been one of the ways we've been recently getting patients diagnosed. So many of you are familiar with PRES, but there have been many reports of patients with acute porphyrias presenting with PRES on neuroimaging. And I think several of the recent diagnoses we've been seeing are through physicians who connected PRES to acute porphyrias and ordered the testing. And I also wanted to list some of the most common misdiagnoses we see in the patients. So one of the most common misdiagnoses is urinary tract infection. So these patients have dark or reddish urine, and if they have anything on the urine analysis, they get treated for a urinary tract infection. And the number one drug they get treated with is Bactrim, which precipitates acute attacks. Some of the other misdiagnoses we've seen in these cases is appendicitis, cholecystitis. In fact, many of these patients with recurrent abdominal pain will have had an appendectomy or cholecystectomy before they see us. Some of the other misdiagnoses, gastrointestinal illness, of course, irritable bowel syndrome, ovarian cysts. So if you're seeing patients with these recurrent abdominal pain and you do not have a clear diagnosis, an acute porphyrias would be something to think about. So the diagnostic testing in these disorders is simple. The single most important test is urine porphobilinogen. And this can be done on a spot sample of urine. Some of the older literature suggests that this should be done on a 24-hour sample. It's not necessary. In fact, it leads to delays in diagnosis. And it's important to collect the sample during an acute attack. So here's a flow chart to simplify the diagnostic testing in these patients. If you have a clinical suspicion of an acute porphyria, check urine PBG. If the PBG levels are normal, you've ruled out the acute porphyrias. But if the PBG levels are elevated, this patient does have a confirmed diagnosis of acute porphyrias. At that time, it would be, you could refer this patient out for secondary testing, including genetic testing. So I put in this EPIC order set to show you that we actually do this test in-house at Sinai. This is done as part of our biochemical genetics lab, which is now part of Semaphore. If you type in porphobilinogen, you get this test. We typically test ALA and PBG together, and it can be sent in-house through EPIC. I just want to say a quick thing about urine porphyrins. I know these tests sound very similar, but urine porphyrins are not the diagnostic test for this disorder. This is the test most commonly ordered for these patients, unfortunately, and most patients will have some non-specific findings, which leads to a lot of confusion and misdiagnosis. So the test to remember is urine porphobilinogen. So how do we manage these patients? I want to emphasize that these patients present with true medical emergencies. They are extremely severe when they are in the emergency room, and they can progress very rapidly if they're not managed correctly. So the first rule is to do no harm. So if the patient has received any offending drug, to remove that drug, and more importantly, make sure you don't administer a drug which could worsen the symptoms. The second step is to give these patients high-dose dextrose fluids. We typically give D10, and D10 has some beneficial effects in suppressing ALAS1. So this is the way you start, with some hydration with D10. These patients have very severe nausea and vomiting, and antiemetics such as Phenergan or Zofran can be administered to these patients. And they have extremely severe pain. So if you ask a patient with acute porphyrias, how bad is your pain on a scale of 0 to 10, almost everyone will say it is an 11. And we want to make sure we maximize pain management for these patients because they really struggle with this. These patients get hypertension and tachycardia, and our treatment of choice is IV labetalol. And of course, if these patients have hyponatremia, you want to make sure you pay attention and correct that. And these patients are also very susceptible to have seizures during admission. The drug of choice is Ativan. Just wanted to point out that phenytoin and some of the other drugs used can actually make these attacks worse. But the definitive treatment for this disorder is Heman, and we believe that any patient who has symptoms severe enough to get hospitalized needs intravenous Heman for management. Heman is a blood-derived product which is administered intravenously, and it depletes the hepatic heme pool, which provides negative feedback repression of ALAS1, can decrease the overactivity in the pathway, and control the symptoms. This drug is given IV daily for about 4 days and is given at a dose of 3 to 4 milligram per kilogram. And it's on formulary here. Our pharmacists are very comfortable with this drug. So this is what Heman does. Many of these patients will have elevated levels at baseline, but during acute attacks, the ALA and PBG levels increase significantly. But if you administer Heman, these levels come down rapidly. By about day 2, the patient's need for pain medications decrease. And by day 4, these patients are feeling much better and ready for discharge. So once the patient is managed acutely, if there is no established diagnosis, at this time they could be sent to a specialty center such as ours to do second-line testing, which includes genetic testing for confirmation. So I want to briefly mention the other 2 acute porphyrias, hereditary coproporphyria and varicate porphyria. I mentioned that the acute attacks are similar, but in addition, these patients can have skin manifestations. They get blistering on the dorsum of their hands, and in some patients you can just have these skin manifestations and no acute symptoms. But these are extremely rare. I don't anticipate that you'll be seeing a lot of these patients in your practice. So a lot of what we do when we get a patient is counsel them. We talk to them in detail about the disease, the inheritance, talk to them about these precipitating factors, and how to prevent acute attacks. We encourage these patients to get medical alert bracelets with their diagnosis, because during these acute attacks, they have an altered mental status, they're unable to inform physicians about their diagnosis. And we also inform them about publicly available resources like drug databases. There are 2 online drug databases, one by the American Porphyria Foundation and the other by the European Foundation. And these are searchable drug databases where you can type the name of a drug and they'll let you know if it's safe to use in acute porphyrias. In fact, this is a resource we use as well. The other thing we do is test family members using genetic testing. So while we know most patients will be latent, testing family members is essential to advise them about avoiding these precipitating or triggering factors. So while a majority of patients, once we counsel them and manage them medically, do quite well and only have attacks sporadically, a subset of patients will develop recurrent attacks. And by recurrent attacks, I mean those patients who have 4 or more attacks per year despite medical management. And these patients become very challenging to manage. Some of the strategies we use for management of these patients is giving them outpatient heman therapy. So heman can be given prophylactically on a set schedule, monthly, weekly, every 2 weeks, or it can be administered in the pre-symptomatic phase of the disease as in an outpatient center. So every facility, every hospital does not have the ability to give this as an outpatient, but really limits this. But at our site, we're able to give prophylactic heman therapy and actually have been quite successful in keeping patients out of the hospital. One of the other therapies which can be used in women who have recurrent attacks related to their menstrual cycle is gonadotropin-releasing hormone analogs, such as Lupron. We personally don't have great experience with this. I don't like using Lupron in young women in the childbearing age, and it has its own complications. And the treatment of last resort in these patients is liver transplant. I showed you the case of liver transplant earlier, and to my knowledge, there's only been one other liver transplant in the US after that case. But this is not frequently used because of the significant morbidity associated with liver transplant. I also wanted to mention that liver transplant does not reverse the neurologic manifestations of this disorder. So if a patient has residual neurologic damage, such as a foot drop or any other type of neurologic damage, liver transplant will not cure that. So besides these acute symptoms, these patients also develop chronic symptoms. And in fact, we've been discussing the nomenclature of this disorder because it's no longer an acute disorder for patients who have recurrent attacks. It's more acute on chronic symptoms. Some of the commonly reported complaints in these patients are chronic pain, fatigue, anxiety, nausea. And as you can imagine, many of our patients are on chronic pain medications. Some of them become opioid dependent, and it's a real challenge to manage their pain. And we typically try to refer these patients with chronic pain to pain management to make sure their pain control is optimized. Besides all of these patients have a long-term risk of other issues. They have an increased risk for hepatocellular carcinoma, which is well documented. In fact, we screen these patients for hepatocellular carcinoma above the age of 50. They also have a risk for chronic renal failure. About 60% of these patients or more will develop chronic renal insufficiency. These patients develop hypertension during acute attacks, but this hypertension can become chronic and compound the renal insufficiency. I already mentioned the chronic pain and neuropathy. Fatigue, anxiety, depression, again, common things you see with patients who have such disorders are present in our patients as well. And then we have the complications of long-term therapy. Patients who receive prophylactic heman are at risk for iron overload. Heman contains about 9% iron by weight, and chronic therapy with heman can produce hepatic cirrhosis, which can become an issue for these patients. And we also have complications related to gonadotropin hormone-releasing analogs, including osteoporosis and others. So these are complex patients and need multidisciplinary care. I wanted to mention some of the newer research in this disorder which we hope to use clinically. I mentioned that chronic kidney disease can occur in about 60% of patients with acute porphyrias, and this is because ALA accumulation can promote tubular cell death and tubulointerstitial damage. So there's a group in France who found that certain genotypes in the PEP-T2 transporter, the peptide transporter 2, which is expressed in the proximal tubular cells and mediates resorption of ALA, can influence the risk of chronic renal disease in AIP patients. The 1,1 genotype in the PEP-T2 transporter has a higher affinity for ALA resorption, and patients who have this genotype are actually at increased risk for renal disease. And we hope to use information like this to identify high-risk patients and manage them differently. So I want to switch gears and talk about newer therapies. Dean Chani spoke last week about translational research at Sinai and early-stage drug development. And this therapy I'm talking about, I think, illustrates our potential to do translational research here. So this is a novel therapy. It is a siRNA therapeutic. So siRNAs are naturally occurring mechanisms in the body which are used to control gene expression. And siRNA therapeutics are novel therapeutics which use the same mechanism but can knock down expression of a target gene with selectivity and specificity. So there's currently an siRNA targeted to hepatic ALAS1 in clinical development. And this siRNA binds to the complementary ALAS1 mRNA, and it cleaves it, reducing the amount of ALAS1 protein. Some of the preclinical work on this drug was done in Dr. Desnik's lab by my colleague, Makiko Yasuda, and they used the mouse model of acute intermittent porphyria. They administered siRNA targeted to hepatic ALAS1 intravenously on day 0, and then induced acute attacks in the mouse model by giving increasing doses of phenobarb, which is a known inducer of acute attacks. And what they found that in the mouse model where they administered phenobarb, there was an increase in ALA and PBT levels. But in those mice who were pre-treated by the siRNA therapy, there was no increase in ALA or PBG, suggesting that this could protect them from acute attacks. And similar results were seen in plasma and urine. So these proof of concept preclinical studies led to the development of gibosiran, which is the investigational RNAi therapeutic. As I mentioned, the therapeutic hypothesis in this drug is there's increased amounts of ALAS1 protein in acute porphyrias. It produces ALA and PPG, which induce symptoms. But this drug can decrease the upregulation of ALAS1 and knock down the amount of ALA and PBG produced. So the drug in clinical development is a bit different from that used preclinically. This is a chemically modified form of the drug with a GalNAc conjugate, which is targeted to a liver receptor. And this is administered subcutaneously and not intravenously. So a few weeks ago, I attended a grand rounds on cardiology clinical trials, and there were 6,000 and 8,000 patients enrolled in these studies. We do things quite differently in the rare disease world, and this phase 1 clinical trial has 16 patients worldwide, and we have 4 of these patients at Mount Sinai. So this clinical trial is currently in its open label extension study, and I'm going to show you some of the phase 1 results, which I think are quite exciting. So this clinical trial had 4 different dosing cohorts where they used doses of 2.5 milligram per kilogram to 5 milligram per kilogram, and these patients were dosed either monthly or every 3 months. To be included in the study, these patients would need to have recurrent attacks, more than 2 attacks in 6 months or more than 4 attacks in a year, and they had to be quite severe. These patients had a 3-month run-in period during which they had to stop heman therapy if they were on heman, and they were observed for the number of attacks they had, and at day 0 they received dosing. So for those who are not familiar with drug development, phase 1 studies are typically for safety and to select the dose, but this trial was actually a double-blind placebo-controlled study where patients were randomized 3:1 to receive drug or placebo. So I'm going to present the results of the first 3 cohorts, which are publicly available. So if you look at the baseline characteristics of these study patients, as I mentioned, they were quite severe. The number of attacks these patients had in the past 12 months ranged from 22 to about 8 per year. Some of these patients were using heman prophylaxis prior to the study, and their baseline ALA and PBG was quite elevated. So the normal level for PBG is about 1.6, but these patients had a 50-fold elevation at baseline. So they're living with these high levels. And here are the results of the study. They saw that there was a 63% mean decrease in the annualized attack rate in these patients in treatment patients compared to the run-in periods. They compared patients to themselves. They looked at the number of attacks during the run-in period and then looked at the number of attacks during the treatment phase, and there was a 63% decrease. And more importantly, they looked at the decrease in the annualized attack rates for patients on the study drug as compared to placebo. And they saw there was a 73% decrease in attacks requiring hospitalization, urgent healthcare visits, or heme infusions. They also saw that there was a 73% mean decrease in annualized heme doses. So these results look very promising, and while collective data does look good, I wanted to share a story of my patient in this study. This is a patient I've been managing for more than 6 years. She's about 36, she's a mother of 2 kids, she's the breadwinner of a family, and she's been struggling for many years with acute attacks. So despite getting heme weekly and getting Lupron, this patient continued to have recurrent attacks. And if you look at her data in the run-in phase, during a 3-month phase, she had 8 attacks requiring heme. So she was very severe. This patient was dosed at 2.5 milligram per kilogram at day 0. And during the treatment phase, she did remarkably well. So she had 1 attack just around the time of dosing. She already had symptoms when we were dosing her. But during the 3-month treatment phase, she actually had no attacks at all, and this was a huge change in her life. Prior to the clinical trial, the maximum number of attack-free interval for her was about 10 days, and during the study, it was about 169 days. So on a patient level, these drugs truly have the ability to transform their life. So here are some of the safety results from the study. There were no drug-related adverse events or discontinuations. There were no dose-dependent adverse events, and some of the more common adverse events were abdominal pain, headache, nasopharyngitis, nausea, or vomiting. So while these results look good, I just want to caution and say this is a clinical trial with 16 patients, and there's no long-term data. So the jury is still out on this drug. We really need to learn more about it. But with that, I'm going to end and just wanted to summarize a few points. I want to recommend that you consider acute porphyrias in the differential diagnosis of patients who have recurrent abdominal pain without a clear diagnosis. The diagnostic test is simple. It's urine porphobilinogen. It's a simple, cheap diagnostic test. Heme is the first-line treatment for acute attacks requiring hospitalization. And these patients can be quite severe. They can present with chronic complications and need multidisciplinary care. With that, I'm going to end and just tell you a few words about our Porphyrias Consortium. We are part of a 6-site Porphyrias Consortium. This is supported by the NIH's Rare Disease Clinical Research Network. And in fact, we are the lead and coordinating site. And we have about 800 patients with acute and cutaneous porphyrias enrolled in our natural history and interventional studies. So we're hoping with this information we can improve our understanding of this rare disorder and eventually help bring therapeutics to patients. And here's our number. If you have any questions about acute porphyrias, I want to mention that we only see patients with a confirmed diagnosis, but we're ready to help you with any questions about diagnostic tests or if you're considering this in the differential of your patients. Thank you.
A question about the youngsters who seem to be spared attacks of acute porphyria.
Mm-hmm.
Why do you think we are not seeing porphyria at ages 1 through 10 or 15, whatever the young age would be? And how does that help us in our research?
So, very good question. It's not that we don't see attacks at all in younger patients, it's just much more rare. And we typically think these attacks present after puberty, And we think hormonal factors have a role to play in this. But there are pediatric patients who do have acute attacks. In fact, they present a bit differently. They present with seizures as the primary symptom. There's a lot we have to learn about this disorder. So one of the things which we are interested in through our consortium is what is the set point where these patients become susceptible to acute attacks. So we really need to track these patients in natural history studies over time to answer some of the questions you're asking.
So those gene therapy trials look very promising. Are they RNA?
They are RNAi.
And the question I have is, did you expect them to be so long-lived based on the animal model? Because it looked like it was a persistent effect.
That's an excellent question, and actually we did not. So initially when this drug was being developed, they were expecting shorter dosing intervals, but based on their early studies in the phase 1, they thought that the effects of this drug really last 3 months and beyond. So that's why we used 2 different dosing regimens in the clinical trial. But currently we're actually starting the phase 3 clinical trial for this drug in a few weeks, and the dosing interval will be about 1 month.
Thank you very much. Thank you.